So, good afternoon, everybody. Today, we are going to take a panel discussion on role of uterine artery in high-risk pregnancies. This is first topic of color Doppler. In color Doppler, we are broadly having two sections. One is the uteroplacental circulation, and another is the fetal circulation. In this first panel discussion, we will be talking of uterine artery, I mean the uteroplacental circulation. With me are Dr. Ekta Tiwari, Dr. Jyoti Agarwal, Dr. Archana Mishra, and Dr. Shraddha Agarwal is yet to join. If you can introduce yourself, starting from Dr. Archana Mishra.
Sir, good evening, everyone. I am Professor and Head of the Department at Hind Medical College, Lucknow, Sitapur Road. Plus, I am also having my clinic, and I am basically interested in gynaecology and laparoscopic surgeries.
Okay, next.
Hello, everyone. I am Dr. Ekta Trivedi. I am a practicing gynecologist at Indore, and I also perform sonography and color doctor.
Next.
Good evening all. I am Dr. Jyoti Agarwal from Mathura. I have my own nursing home. I have a special interest in ultrasound and infertility practice.
And those who are not knowing me, I'm Dr. A.B. Vani. I'm Director CEO of Bilmed Ultrasound Training Institute. We are here having a training institute by the name of Bilmed Ultrasound Training Institute. The headquarters is in Delhi NCR, and plus to that we are having about 14 branches across the India and 5 international branches also. Till date, we have trained about more than 25,000 doctors, and most of them were 95% were gynecologists only. So today we'll be talking of not talking actually, we'll be discussing about the uterine artery. First, what I will do, I will give you a short theory of the uterine artery, and in second session we will be taking the case presentations also. So, first of all, what a Doppler ultrasound is, how different this Doppler ultrasound is from the grayscale, is that in this Doppler, what we are talking of anything which is moving in the body. Doppler is picking only and only anything which is moving in the body, and in body, blood is moving. So Doppler will be picking the blood only. Now, a brief about the Doppler physics. Very brief. Here we are having some colors, red and blue. This red and this blue is reflecting the direction of the flow in a given vessel. In this red vessel, I am having flow towards the transducer. So towards transducer means the Doppler will show me a red color. And if it is away from the transducer, Doppler will be reflecting the vessel as the blue color. Now, we'll be having flows. This is the baseline over here. I am having baseline here. In this baseline, if the flow is above the baseline, this flow has been taken from red or blue vessel. Now think, Red or blue? Red vessel. So if you take a flow from a red vessel, the flow will be registered on the top of the baseline. Now, why this is important? Because if you take a flow from the vessel which is not red but blue, the flow will be registered on the opposite side of the baseline. On the opposite side of the baseline, that is an invert. That is not reversal of the flow. That is why there is a button in your machine to invert. Anyhow, this is a very lengthy topic. I mean, this physics and these machine settings is a very lengthy topic, which is available on our server, bilmed.net. What we are going today, we are going to have a brief intro about the uterine artery. One more important thing is that the angle of insolation. What angle of insolation actually means? Actually, this is the angle by which you are throwing the beam. By which you are throwing the beam. And if your beam is hitting the vessel by an angle which is less than 60 degrees, you will see a good color. And if the throwing angle is 90 degrees, then you will not see any color and you will not see any flow. These points are very important because, for example, if you are about to talk of, judge a blood clot, whether it is a blood clot and you want to differentiate it from an RPOC, and if you are hitting by 90 degrees, it will not show flow. Then what you will think of that this is not a blood clot, this is not an RPOC, but a blood clot. Actually, you are hitting the beam by 90 degrees. So this is the importance of the angle of insolation. The angle of insolation should be less than 60 degrees. Lesser the angle, good the flow. More the angle, worse the flow. And if the flow is if the vessel is hit by 90 degrees, you will not see any color. That is the point. So this is brief about the angle of insolation. Here we are showing in A, I am having a lesser angle, and in B, I am having more of angle. That is why in A, you are seeing a good flow, and in the subsequent B and C's, you are seeing a dampened type of wave, and in between C and D, if you hit by 90 degrees, you will not see anything on the screen. And if you hit the beam, if your beam is hitting by more than 90 degrees, I mean an obtuse angle, maybe 120, 100, the beam, the flow will be registered on the other side of the baseline as shown in the D. So that is not actually a reversal, but an invert wave. So this is about a very, very basic about the physics of this color Doppler. Now, in gynae-obs practice, if you are a gynecologist, your Doppler is having a role in infertility, ovarian disease, endometrial disease, disease of uterine body, pregnancy complicated by diabetes. In ectopic pregnancies, is having its role in post-dated pregnancies. In multiple pregnancies, Doppler is of use. In fetal hydrops, Doppler is of use, and we do have Doppler echocardiography also. But the point is, if you are having 100 OPD, for example, 100 patients are referred to you, or you are scanning 100 patients, I mean the color Doppler, you are performing on 100 patients, about 95, if not 96 or 97% will be for Doppler in fetal hypoxia only. The rest list, the long list from top to bottom, will not be of more than 5%. So if you will understand the Doppler in fetal hypoxia, your bulk of the OPD is already covered. So we are today starting the panel discussion on this Doppler in fetal hypoxia, and the first you can say the first topic or the first panel discussion will be about the uterine artery. Now, in this Doppler in obstetrics, by the use of the Doppler, you can see that how the postnatal mortality is decreasing with the use of the Doppler. With the invent of the Doppler, this is of course decreasing. So this shows the importance of the use of the Doppler in your day-to-day practice. Now, coming to one important point, and that is the small for gestational age fetuses. Whenever you are having a small for gestational age fetuses, you are having, you have to differentiate whether I am dealing with a constitutionally small or a true IUGR. And here comes the role of the Doppler. And what is behind this constitutionally small and this IUGR is actually a low growth potential and low growth support. Here we are not taking a course. Try to understand, whosoever is watching this video, whether on any social platform, we are not right now taking a course. We are taking a panel discussion. And before this panel discussion, I want to give you some theory of this. So don't take this as a course. Go through your books first, have some basic understanding of the fetal color Doppler. I mean the OBS color Doppler, I will say, not fetal. And then you will see that you will understand me in a better way. And with Bilmed, we are having about a 2 months course of this fetal color Doppler. So coming to this small for gestational age fetus, here the main point is whether I am dealing with a low growth potential or low growth support. That fetus, if that fetus is having a low growth potential, that will be an constitutionally small fetus. But if it is having a low growth support, that is an asymmetrical IUGR. Now Doppler. If Doppler is showing you, I mean this uterine artery, for example, is showing you an abnormal flow. We will talk of this uterine artery in coming minutes, that how the flow is looking like. But the point here is that if uterine artery is abnormal, there are very, very high chances that you are not dealing with a constitutionally small fetus. You are dealing with an IUGR. So one click, uterine artery is differentiating whether I am dealing with a constitutionally small fetus or an IUGR fetus. Now, in OBS Doppler, as already told, that we are having two circulations. One is the uteroplacental circulation and another is the fetal circulation. Today, in this class, in this panel discussion, we'll be talking of the uteroplacental circulation, and we will be investigating this uterine artery over there. Now, where to scan? That is not the topic for now, but anyhow, I will give you a brief of the tips that you see a crossing vessel. If you detect a crossing vessel where the iliac vessels, whatever the vessel is crossing is the uterine artery, so better see for an iliac vessel, because iliac vessels are easy to pick. So then see for a crossing vessel. The crossing vessel has to be the uterine artery. Now, the diameter of this uterine artery is increasing from a first trimester to third trimester. There is a dramatical increase of the diameter. Also, I will talk of the flow, but first the diameter in a non-gravid, it is about a 1, but near term it is about a 5. So here is the blood flow, which is increasing again from a early pregnancy to term. In a non-gravid, it is about 50 mls per minute, but there is a dramatical increase. It goes up to 500 milliliters near term. Now, this is very important to understand. You have to understand why there is so much of dramatical increase in the blood flow of the uterine artery. For that, I am having two things. One is systematic event and one is the local factor. Systematic events, increase in the maternal cardiac output and other things, the hormonal effect, play a very little role. But the local factor is the main contributory factor for so much of increase in the blood flow of in the uterine artery. And what is the local factor? Local factor is nothing but a trophoblastic invasion. Now the point is, when I am scanning the uterine artery, what for I am scanning the uterine artery? I am scanning uterine artery to know what is the status of the trophoblastic invasion. I don't have microscope. I mean, whenever I'm scanning, I'm having an ultrasound machine. Ultrasound machine cannot show me the microscopic structure, which is trophoblastic invasion, but the uterine artery will tell me the invasion effect. How much is the trophoblastic invasion? If I am having a good trophoblastic invasion, sufficient trophoblastic invasion, I will expect a good flow in a uterine artery. And if the trophoblastic invasion is not up to mark, that will tell on the the uterine artery flow. So in one line, uterine artery is reflecting me the trophoblastic invasion. So this is one point which took me about maybe 5 to 10 minutes. So make a red note that whenever you are scanning a uterine artery, what for you are scanning? You are scanning to know the status of the trophoblastic invasion. Now, if there is a failure in the trophoblastic invasion, that will lead to the impairment of the utero-vascular resistance, and ultimately it will lead to the impairment of the maternal-fetal exchange of nutrients and oxygen, and that will lead to IUGR. Now try to understand. Here, if I am having a weak trophoblastic invasion, this fetus is not IUGR at this particular point of time because I am in early pregnancy. But this fetus can land in IUGR. There are high chances. So this is the role of the uterine artery. So can I say that this uterine artery is for the prediction of IUGR? So this is more for the prediction of IUGR. You can predict that this fetus can land in IUGR. For example, there is a patient in which there is the previous history of IUGRs or preeclampsia, anything. You are scanning and you are in early pregnancy. And if the uterine artery is showing you a weak trophoblastic invasion by its flows, you can predict that this fetus can land. There are high chances of IUGR in this fetus. So this is the main role of the uterine artery. It is more for prediction, and it shows me the status. It gives me an idea rather of the status of the trophoblastic invasion. Now, you should know that what is normal. And if you know that this thing is normal, anywhere in the body, this thing is normal, and if you expect that normal thing over here, and you are not seeing that, that is abnormal. Now know your mango to differentiate it from a potato. That's simple. So let us see how the normal, what the normal is in a uterine artery. In a uterine artery, I am having something which is called as diastolic notch. Now this diastolic notch is normal, but make a red note over here. This diastolic notch should not be there after 24 weeks. After 24 weeks, I will be having more of the diastolic flow. Now see over here, diastolic flow is increased. So I will be having no diastolic notch after 24 hours. After 24 weeks. Now, what about the resistive index? Resistive index is actually a ratio between S by D, systole and diastole. What will you expect in a fetus after 24 weeks? I mean, a resistive index, will it fall down or will it increase? It has to fall down. So resistive index, we will come on these charts later on. So these are the two flows. Before 24 weeks, you will see a notch. And after 24 weeks, there should be no notch in the uterine artery. Now, as pregnancy is advancing from first to third trimester, there has to be a sufficient increase in the diastolic flow. So the resistive index, RI, has to drop towards the end of the pregnancy. Now, compare, you can compare the first trimester and the third trimester flows. Visually, you can see it that it is much more increased in third trimester than it was in first trimester. Now, what is abnormal now? Abnormal is if there is a, you can see a notch over here in first slide after 24 weeks. And if there is a dip in the diastolic flow, drop in the diastolic flow, and if there is a, severe drop in the diastolic flow, that is abnormal. Now, by this time, you should be able to see, for this diastolic notch. And now see, our diastolic notch is over here, and see visually. Not always you have to trace the artery. See visually, is there any diastolic flow? There is hardly any diastolic flow in second slide, and in first one there is a less of diastolic flow as compared to normal. So this thing, if seen in third trimester, it is very, very abnormal. So a retention of diastolic notch is having a sensitivity of about 90%, specificity touching 90, positive predictive value also touching 90, and negative predictive value crossing 90. What else you want from more from a diastolic notch? So have a understanding that if notch is there after 24 weeks, it is very, very abnormal. And if it is up to 24 weeks your gestation, and it is completely normal. So this is the importance of the diastolic notch. There can be the difference of the uterine artery right to left. It depends on the placentation, and the 10% difference is accepted. But again, you have to see for the placentation. If placentation is on the right side, you will expect the uterine artery of right to be more than, I mean the diastolic flow of more than as compared to the left one. So the significant difference should not be there, but a minimal difference of about a 5 to 10% is accepted. But if there is a significant difference between two vessels, that is abnormal. Now, we are having something which is called as, resistive index. Resistive index. By resistive index, it is actually the systole minus diastole divided by systole. You don't have to put your mass in action. Machine is doing the job for you. At the end of the scan, machine is giving you the resistive index. So the formula behind this resistive index is S. Now see, PSV means peak systolic velocity. So the systole minus EDV, end diastolic velocity, D, divided by peak systolic velocity, and machine is giving you the resistive index. Why I am spending time on this is that you can make out from this formula of this resistive index that if there will be the drop in the diastolic flow, what will happen to resistive index? Try to understand. If there is a drop in the diastolic flow, what will happen to resistive index? Now do some maths yourself so that you can better understand. RI will increase. So end diastolic flow, whenever dip is in the diastolic flow, the rise is in the resistive index. That is why whenever you are having a high resistive index, it is actually you are having a low of the diastolic flow. So resistive index high does not mean high resistance. It means that I am having a low of the diastolic flow. So here are the charts. Now over here, you can see that the resistive index is dropping from 20 to 40 weeks. What actually this means? This means that the diastolic flow is increasing. It is because of the increase in the diastolic flow that the resistive index is dropping. So a 0.5 on, about 20 weeks is normal. But same 0.5 is abnormal for 36 weeks. Because the resistive index should drop Again, repeating, by drop in the resistive index, I mean there has to be an increase in the diastolic flow. So you can download these charts. These charts are available at your fingertips. See for these charts, 0.5 as already obvious from this chart is normal up to 20 weeks, but at term, their resistive index should be about a 0.4. And on the left side, you can see the pulsatile index, PI. PI is also calculated depending on the PI is also depending on the this diastolic flow. So the funda is same. Now, the point, what is arising? If you are having an abnormal uterine artery flow, what to do? These are the questions which will arise. What to do? How safe the fetus is? What is the status of the fetus right now? How much I can stretch this pregnancy? And when to terminate the pregnancy? Do we have answers to these questions? Yes, we do have. But repeating, this is not a course right now what we are taking. Number one, for courses, you have to enroll for, a color Doppler. Go to any institute. Go through the books. Then you will understand in a better way. That is one. Second is that we are not today going to take the fetal circulation because it will be a very lengthy panel discussion there. Now, coming to these questions, do we have answer to these questions? Yes, we do have. But for that, I have to understand the fetal language, and fetal language is nothing but these vessels, the fetal vessels, fetal circulation, umbilical artery, descending aorta, middle cerebral artery, inferior vena cava, umbilical vein, and your favorite ductus venosus. Uterine artery alone is not giving me the conclusion. Uterine artery is for prediction and to start your color Doppler. So this is the role of the color uterine artery flow. Now I will give dice to the panelists so that they can add on their points and they can discuss some cases over here. So, Dr. Archana, if you can unmute yourself.
Yes, sir.
Dr. Archana, you have something to add?
No, sir, it was very well explained, and I think the basic concept of this uterine artery Doppler and its significance is very well elaborated and understood.
Do you want to top up or add on anything?
Actually, we must these days. I don't think many of us are doing first trimester Doppler, but it should be done to know the early diagnosis of the preeclampsia or if this is going into hypoxia. Yeah.
Dr. Ekta?
Yes, sir.
You have anything to top up?
No, sir, you explained everything very well. I think we should start with the case discussion, Archana ma'am.
Yeah, we are going to start it. Dr. Agarwal? Dr. Jyoti Agarwal?
Yes, sir.
You have anything to add on?
So I just want to say nowadays, obviously, uterine artery Doppler is a good screening method for PIH, for IUGR, prediction of IUGR and PIH. In anti-NB scan, mainly in anti-NB scan.
Yeah, you rightly said that. Now see, in NB scan, you have to add one vessel, and that vessel is the uterine artery.
Uterine.
Because by taking a uterine artery only, you are making sure that not 100%, but about a 95% that this fetus is not going to land in IUCR. And if there is an abnormal signal from the uterine artery, you will be on red alert that this fetus is going to land in IUCR. So this is a so you haven't had to add in your level 1 NBNT scan. And don't accept the report of level second without artery. Because that doctor, whosoever is doing, if you are doing, you have to have added the uterine artery, irrespective of whether the patient has come for color Doppler or not. So this is not the part of the color Doppler when I am taking level 1 and level 2. It is the mandatory tool. It is the tool which is, giving you a signal of, of red or green. I mean that if it is abnormal, be assured that this fetus is going to land in IUGR, and you can predict months before to patient that you color Doppler at 30, maybe a 32 weeks. Anything else? Okay, now I will share one case discussion which was given by Dr. Archana Mishra. Just hold on. So, Dr. Archana, over to you. This is your case. Uterine artery Doppler study. The case study. The moderator will be Dr. Archana Mishra, and we all rest will be panelists over there. Now, the case is we are having a patient XYZ. The age first. See to the age. 38 years. Keep these 38 years over here. G5, P1, L1, and 2 abortions. Now, history of previous preeclampsia in all past pregnancies. And there was one child, male, full-term normal delivery, 12 years before. After 3 consecutive pregnancy terminations of 24 to 28 weeks because of severe preeclampsia, she came to your clinic with 7 weeks live intrauterine pregnancy. Pay attention to the blood pressure. Blood pressure was 180 and 110. Now,
yes, sir, actually
will be arising, and which has to arise. What is the first thing what I have to do? What investigation will we advise to this patient, and what will be the drug of the choice? What prophylactic treatment we can go for, and when the pregnancy should be terminated, and future fertility considerations. Over to Dr. Mishra. Dr. Mishra, these will be the questions which will come up right now.
Yes, sir. I will be actually asking one by one to all the panelists. Sir has already elaborated with the case. Actually, this was the practical and live case of Dr. Ekta. So I would like her to share her experience with it.
Yeah. Thank you, everyone. The first thing what we will do, the patient came us with the bad obstetric history. Her age is 38 and her blood pressure is very high, 180 by 110. So first trimester counseling regarding the screening for aneuploidies, screening for the renal parameters, see how is her renal Doppler, how is her cardiac ejection factor of the mother, and keeping this pregnancy to be turned into severe preeclampsia. Our aim is to give the counseling first. See, this is a very high risk pregnancy. It may reach up to term, may not reach up to term, but first thing we started antihypertensive to her. Then in the first trimester, we rule out the chromosomal aneuploidy by cell-free DNA test. And then along with the routine care with the iron and the dupestone and L-arginine and antihypertensive medicine, at 11 to 13 weeks, we performed an anti-NB scan along with the uterine artery Doppler. And in that, the uterine artery Doppler shows very high resistance in the uterine artery. This is the first trimester given to her.
Okay, so what drug you would like to see if there is changes in uterine artery Doppler and she is already having the previous history of preeclampsia and fetal loss and bad obstetric history? My question to you, Dr. Ishita, like what would be the your drug of choice, like to prevent, what would you like to add on this?
Good evening, ma'am. Ma'am, I would like to start tablet aspirin, 150 milligram.
Yes, yes, a prophylactic.
Prophylactic.
Yes.
I would like to test for APLA also, ma'am.
Yeah, because
And
the previous
PAPE,
losses of
because of severe preeclampsia, and PAPE also, pregnancy associated plasma protein. This value should be more than 0.5 MOM.
Okay, so you would like to go for the other causes of the previous loss along with this. She's high risk for preeclampsia and she's already presented with very high BP, severe preeclampsia. So you would like to add that drug
Liver
also.
profile, kidney profile, thyroid,
All the
diabetes.
investigations will be done.
Ji, ma'am.
Can I have that questions, right? Like after this, how would you proceed further, like in second trimester? What routine
Uterine artery,
investigations?
the main investigation is her uterine artery Doppler in level 2 scan. This mean uterine artery PI should be less than 2.5.
Okay, okay. And you will advise her like complete bed rest or
Ma'am, calcium intake should be twice than normal. Aspirin will continue, antioxidants will continue, and proper this management of blood pressure. This is most
Yes.
important. Low salt diet.
role of magnesium adding in this with the vitamin D3 in first
Ma'am,
trimester.
vitamin
We
D,
can add.
yes, we can add vitamin D3
D3.
and magnesium also.
Yes, sir. Sir, would you like to add in the any investigation part in this?
I would like to, discuss something with you regarding this case. Is that will you expect? First of all, how much was the gestational age over there?
7 weeks. She came
7
to
weeks only.
early,
Okay,
yeah.
if you are taking a uterine artery, what you will expect, how much of the resistive index you will expect in that patient, and when you will label that uterine artery to be normal or abnormal? 6 weeks, 6 weeks only.
Yeah.
6 or 7 weeks. How much has to be the resistive index to make it, normal or label it as abnormal?
So normally in 6 or 7 weeks, we don't do Doppler.
Yes.
Now, will you leave this patient without Doppler of uterine artery, not of fetus, with uterine artery? Will you leave that fetus without uterine artery for now, or you will take the uterine artery at level 1?
I think we will leave right now.
You will leave right now. Okay. Now, when you will start your Doppler?
So in level 1 scan.
At
level 1 scan.
level 1. Okay. At level 1, in 13 to 14 weeks, how much the
12 weeks.
PI or RI, anything, has to be to label it as normal or abnormal?
PI should be less than 2.5. Mean uterine artery PI should be less than 2.5.
And what about the resistive index, RI?
It should be less than 0.5.
Right. Okay. Now, if you will scan this patient and your uterine artery for now is giving you a bad signal. Bad signal means that there is a high PI and RI. At 20, not 20 actually, at 30 weeks, what you will scan more? Which vessel you will scan more?
Then we will proceed for umbilical, then middle ductus venosus, middle cerebral.
Okay. One last thing. What ductus venosus is reflecting me, as we have discussed today, that whenever I am scanning the uterine artery, it is giving me a understanding of the trophoblastic invasion. What ductus venosus will give me?
Fetal
It reflects
acidosis.
fetal acidosis.
Next question. Will you allow the fetus to touch the abnormal ductus venosus flow? Not to land,
No.
touch.
No, sir.
Never ever. So the ductus venosus will never ever, be the criteria, but there has to be a correlation of other vessels. I mean, the middle cerebral artery, maybe an inferior vena cava and umbilical vein, but don't wait up to the ductus venosus to give the wrong signal, because if the ductus venosus is giving you a wrong signal, by wrong signal I mean the abnormal ductus venosus,
Sir,
it
your
means that
voice is not clear.
acidosis has already occurred, and if you take that fetus out, there are high chances that you'll be losing that fetus.
Yes.
Okay.
You should also look for
which I
the
want to add on.
persistence of the
So
diastolic
these all
notch.
things are in fatal situation. Actually, we have today discussed about the uterine artery. What is this?
Sir, also the persistent of diastolic notch
Those
should be
who
taken care.
are live on YouTube, please post in the comment box so that we can discuss their queries, or if they want us to elaborate any point, we will elaborate over there. So whosoever is watching this panel discussion on YouTube, please post in the comment box. We will be waiting for next 20 to 30 seconds. And if there will be some relevant points which has to be discussed, we will be taking that in account. Yeah, we have in the comment box. Anna. So there are many comments, good and nice discussion, but I don't want appreciations. I want your suggestions. If you have any suggestions, if you want me to elaborate any point, or you have any suggestions, or even if you want any thing which has to be taken in our next panel discussion, you can post in the comment section so that we can manage our next panel discussion accordingly.
Sir, one thing I would like to add.
Come again, please.
Yeah, one thing, like there should not be the persistence of the diastolic notch, that should be taken care.
Yeah, very important point. That if, now see, there are two things. One is the drop in the diastolic flow,
Yes.
and another is the diastolic notch.
Persistence.
More dangerous is the diastolic notch. Both are dangerous for fetus, but more dangerous will be the diastolic notch if retention any. I will say it, in other words, I will say that I will say, thank God it is the drop in the diastolic flow only, and it is not a diastolic notch, because if there is any diastolic notch, I have to be on red alert, double red alert, I will say. Now there is Dr. Asha Gangwar. Okay, there is a question over there in the comment box. Role of NO, I'm not making it out. Ecosprin increases uterine artery PI at 12 weeks. Dr. Archana Mishra, if you can take this question. Can you see the comment box over there, Dr. Archana? Yes or no?
No, sir.
No. Okay, I will dictate you. Role of ecosprin increase uterine artery PI at 12 weeks. That is,
yeah, it increases the perfusion, uteroplacental circulation. That's why we are giving to increase the flow.
Okay, Dr. Hanif Khan is posting which drug to use.
Labetalol.
No, not for BP, ecosprin.
Ecosprin. If you can add the dosage also.
75 milligram.
75. Okay, and that will be OD, right now?
Yes.
Okay.
So I want to add,
Yes.
as she is a case of severe preeclampsia plus history, very bad obstetric history, I would like to give 150 milligram. Plus, its dose depends on weight. If weight is more, OD, HS.
Yeah.
Same,
you can give divided doses, or you can give the OD. Like divided doses will act better.
So it will be divided in BD or OD.
BD, 150 OD. Instead, we can give 75 in BD doses.
Sir.
Actually, I lost my connection. I think.
Alpha testing. Dr. Sanjita Saja is posting. Alpha testing, is there any use to do while pregnant?
Which testing, sir?
APLA.
Alpha.
APLA testing.
Apla. Sorry.
Yeah.
There is a mistake over here. Apla testing.
Yes, sir. It has a role.
Mhm.
It reflects the immunological causes of the miscarriage, and if APLA testing comes positive, then an obstetrician is supposed to start low molecular weight heparin so that we can maintain the uterine perfusion very well, and immunological causes of the pregnancy damage and loss can be minimized. So APLA testing has its role. We tested for APLA, it came to be negative.
Okay. Next question is there. There are many questions now coming up. Next question is just hold on. Dr. Narayan is posting, sir, what if there is only one uterine artery PI is more than 2.5 at the time of NT? Is it significant or not? These are, this is the language, what is written up there. I am just reading the questions. I will take that question. Now, what Dr. Narayan wants to clear, how much the significance has to be there. We have already touched it, that there should be not much of significance between the two uterine arteries. But the point here is that you have to see the placentation. If placentation is on the right side, I will expect more diastolic flow in the right one than in left one. It means that the right-sided PI should be less than the left one. But if the placenta is fundal, I'm trying to understand, if the placenta is on the top, I mean the fundal, then I will not expect much of the difference between the two vessels. So you have to see both things, placentation and not much of significance. How much the significance will be? Not more than 10% of whatever PI or RI you are seeing over there. We have more questions over there. So let me.
Can we discuss another question?
Now, sir, nice discussion. Pregnancy of Ethna Doppler, 24 weeks, umbilical Doppler showing early diastolic. So, Dr. Mujibur Rahman, I will take it. This will be the last question. What I will take now. Sir, nice discussion. Pregnancy of 24 weeks, uterine artery showing early diastolic notch and umbilical artery showing reduced end diastolic flow to absent end diastolic flow. What should be done and what is the prognosis of what to interrupt, when to interrupt? Now, see, I will sum up the long question. It is not actually a long question. It is a very short question. It has to be very, very long because this will cover whole of the color Doppler. Now, the question is over here from Dr. Mujibur Rahman is that there is a patient of 24 weeks and the Doppler ultrasound is showing an early diastolic notch. So first gestational age 24 weeks and still there is a diastolic notch. That is the worrying sign first, that why there is a diastolic notch, because I told you that the diastolic notch is very dangerous. And here the patient is 24 weeks. Number second, he has taken the umbilical artery also, and umbilical artery is giving a wrong signal. Wrong signal means abnormal end diastolic flow. That is what is written here, reduced end diastolic flow. It means that the placental obliteration has started. We have not touched it today, the fetal circulation, but the question has popped up, so I will touch it. It means that placental obliteration has started, and when to terminate the pregnancy, that is the next question. Now, only umbilical artery and uterine artery will not give me any, any idea of when to terminate. But other vessels, middle cerebral artery, inferior vena cava, aorta, umbilical vein, That is the fetal circulation, what will decide when to terminate the pregnancy and how safe the fetus is. Because in start, I told you in beginning that we'll be today taking the uterine artery only. Next block will be for the fetal circulation. So stay tuned, and you can comment. If you are watching this offline also, you can comment in the comment boxes for next panel discussion, and depending on the comments, how much comments we will get over there, we will arrange the next blog, not actually a vlog, a panel discussion. And we will be keeping an eye, our team rather will be keeping an eye on the comment box, and whosoever will give us a good comment. By good comment, I don't need your appreciations, again repeating, a good question or a good topic in the comment box, we will give a a memento to him. Then this is the memento which will be given, and our team will ask for the this address, and we will send that memento to that person who will give us who will be having a good question, and will suggest us at the next interactive panel discussion. Stay tuned and subscribe to our channel, and please press onto the bell icon, I mean the notification, so that there will be some notifications about our next case discussion. Thank you.